Hi, everyone. Thank you all for joining us for the 2026 APAMSA Internal Medicine Bootcamp. My name is James. I serve as y'all's internal medicine student representative. And we're really grateful that y'all are all here today, and I'd like to pass the mic on to our alumni director, Kelly Poo.
Thanks, James. Hi, everyone. I'm Kelly. I oversee the strategy branch of National APAMSA that puts on these boot camps every year. Like James said, thank you all for being here, and also thank you to our wonderful speakers for taking time out of their busy schedules and Sundays for being here as well. We saved the best boot camp for last, so welcome to our internal medicine boot camp. We've been hosting these boot camps for a few years now, and internal medicine is always one of our most popular, most well-received boot camps, and it's all thanks to our incredible speakers who come back every year. So we hosted 11 boot camps this year, ranging from pediatrics to EKG, and this is our last boot camp for the year. But the recordings of the boot camps will be available on our YouTube in a few weeks. Additionally, when you leave this Zoom, a post-session feedback
This
form
is a
will pop
security
up, and if you
advisory.
fill that out
Please
and leave
maintain
your
your distance.
email, you'll be sent a copy of these slides in 1 to 2 days. So thank you all for being here, and I will pass things off to
Microphone disconnect
Victoria.
on.
Thanks, Kelly. Hi, everyone. I'm Victoria Sigielski. I am part of the National APAMSA Alumni Board and a former national board member of APAMSA. And as Kelly said, thank you all for joining us for our 11th and final bootcamp series, Internal Medicine. Today's Internal Medicine Bootcamp is aimed at providing high-yield tips and approaches to commonly encountered scenarios and finding out ways to set you up all for success. I'd like to thank our amazing panelists, Dr. Sampath, Lynn, Chen, and Hu for preparing this fantastic bootcamp. And I'm now going to hand it off to our wonderful subspecialty student section leader, James, to orient you to today's format.
All right, so we would like to make this as interactive as we can. So if y'all have any questions while our residents and attendings are speaking during their presentations, feel free to put them in the chat box. And also, if we do have time and the speakers are open to it, feel free to raise your hand on the Zoom kind of screen, and we can go from there. Oh, sorry. Oops. Actually, I'd like to pass on the mic now on to Dr. Lin, who will get started by introducing himself.
All right. Hey, everyone. I'm Ming. Really nice to be here and share with you all and just providing a lot of good information along with the other speakers today. I grew up in the Chanhassen area, right outside the Twin Cities of Minnesota, but depending on kind of the particular day and season and mood, I may say that I'm also from Boston because I spent about 10 years there, did my undergrad, did a master's there, and worked for about 5 or 6 years as a community health worker before starting med school. I did my med school training over at MCW or the Medical College of Wisconsin, and currently am a second year IM categorical resident there as well, and really loving it. Things do get better after intern year, as I'm sure my other panelists will attest. So the light is definitely growing larger at the end of the tunnel. For me, that's applying for more training in HEMONC, which I'm also really passionate about. So if any of you are interested in HEMONC or want to just talk more about it and network, feel free to message me separately too. Outside of work, when I do have time, I love to cook. I love board games. I love making purchases that are way beyond my means, including things like a Breville. And also just really ignoring all the emails about student loans and credit reports and things like that, because who has the time for that these days, right, in this economy? So again, really happy to be here. Thanks so much for having me.
Hey everyone, my name is Tiffany. I'm from Rockville, Maryland. I did my training initially at the University of Michigan for med school, and then I did my residency training in the categorical program at Yale Internal Medicine. I am currently a PGY4 Geriatrics fellow also at Yale. And I guess, sorry, this is outdated from last year's slides. I'm not heading to geriatrics fellowship. I'm finishing geriatrics fellowship because it's a 1 year program, which is splendid. So I'm almost an attending and currently in the process of figuring out job stuff afterwards. Outside of work, I love caring for our plants, loving my cats, Miko and Nori, and we live dangerously close to a lot of really cute cafes and restaurants, especially one ice cream shop in East Rock, New Haven. So we eat a lot of ice cream here too.
Hi, everyone. I'm Ramya, and I can definitely agree with Tiffany's assessment of the ice cream shops that are delicious. As I also met Tiffany in my residency training and can attest, we eat a lot of ice cream. So I grew up in Sunnyvale, California, and I went to medical school at the University of Rochester, where I met Spenser, who will be the next speaker. And then I came to Yale Internal Medicine for residency, where I met Tiffany. I am currently a PGY3 and looking forward to this long tunnel coming to an end, and actually a little bit of FOMO already about not being in training or in internal medicine training. I'm like, oh my gosh, what if I miss the pancreas when I'm doing cardiology? Um, I'm still very excited to be starting the National Clinician Scholars Program for the next 2 years, and then cardiology fellowship for the 2 years after that. So if anyone is interested in those things, do feel free to reach out. And outside of work, you can't see my many hundreds of plants, but I have hundreds, and I like to take lots of sick plants from other friends and take care of them. You can't hear my dog whining, but she is whining because I did not yet take her for a WALK. And I'm still drinking endless coffee, and I also like learning languages and hanging out with my friends. I'm happy to be here with you all.
Hey everyone, welcome. I'm Spencer. I'm originally from Taipei, Taiwan, and also California. I did have the unique privilege of going to medical school with Dr. Sampath, where we were besties. And now I am a third year med peds resident, doing my internal medicine training at Penn and pediatric training at CHOP. I'm happy to answer any questions about MedPeds and what that could look like going forward. I am interested in adults with congenital heart disease applying into adult cardiology this year, as well as cardiac critical care. Outside of work, I love talking to Ramya. Judging bad boba, I do consider myself a boba elitist as a Taiwanese. And I do a lot of union organizing with committees of interns and residents, CIR. So if you're interested in organizing and building power, feel free to reach out as well. And also consulting Ramya on how to resuscitate my plants. And I think we are gonna transfer over to Min to start our talks.
Yes. So we'll give the mic off to Dr. Lin, who will begin our presentations today. And you're all good to go.
All right, thanks so much, James. So, just to kick things off, we hope that all of these really fast and short sessions will primarily serve the purpose of giving you a framework on how to approach these very commonly seen problems and questions, mostly on the inpatient side, especially if you're dealing with acute questions on your overnight shift and really juggling 1,000 things at once, which is a really big learning experience, especially when I remember doing that as an intern year and also currently as well. So the first thing that we'll talk about is how to approach pain, because that is a really big topic that I'll try to fit into about 5 minutes, but here we go. So I think when we think about pain, it's a really broad subject because there are so many ways to conceptualize it, to categorize it, and of course to manage it, because not all pain is equal or the same. I want you to think about, is this, when you're approached with a patient with pain, is this acute pain? Is this pain that they've had for a long time? Is this pain that they've come in with? And what have they tried at home to really manage their pain if it's more chronic? Think about what type of pain it is. What have they tried in terms of interventions, whether it's oral pills, IV medications, patches, topicals, things like that, and really highlighting that pain really should be managed from a multimodal fashion and not just from kind of pharmaceutical intervention. And also thinking about whenever you're choosing an analgesic for a patient, what are the side effects for it, and what are the specific patient specific characteristics that you should be wary of when choosing an analgesic. For example, is this an elderly patient? Are they more prone to being delirious, or are they altered? Are they pregnant or currently breastfeeding, for example? So there are very specific things that you should think about. And who else could you manage to involve to help manage the pain too in the short term and the long term? So when we think about pain, there are kind of three main groups of pain types to conceptualize this, from nociceptive pain, like pain from burns, fractures, skin infections, to neuropathic types of pain, which is like your typical peripheral neuropathy from someone who has uncontrolled diabetes, but also from chemo, radiation, and even chronic infections like HIV. You also think about spinal cord compressions from like a neurologic perspective, if that's contributing to this pain profile. And also, a lot of inpatient patients come in with mixed pain as well. They may have a long history of cancer, especially really advanced stage cancer that's leading to really uncontrolled pain, as well as things like fibromyalgia and, of course, our favorite lower back pain. So I think that there are so many different ways to treat pain that we often become very stunned or flustered when thinking about choosing the right agent to manage someone's pain. What I love to use as a first-line agent, regardless, is Tylenol or acetaminophen. It's generally really effective and to manage all sorts of pain, and it's very harmless to do as well. Although with the caveat of being if someone comes in with really advanced liver disease or liver damage, then this is something to be more wary of. You could also try things like NSAIDs, things like ibuprofen, your Toradol or ketorolac, as well as naproxen, celecoxib. But those have a lot more risks associated with it, including things like GI bleed, ulcers. Really be careful in using this when someone comes in with an AKI, for example, or even a GI bleed. And so this is something that I tend to think more carefully of using when getting that overnight call. And other things like gabapentin, which tends to be a pretty chronic med that a lot of patients may come in with, and things like lidocaine gel, creams, even oral options can be effective too. Um, there are also a lot of opioids that are available too, and these are the things that we have very low threshold just by instinct of reaching for. It's I think we've all gotten a lot of lectures about the side effects of opioids and when to really be more careful of using them. But in general, you want to start these at the lowest effective dose, especially if they come in being opioid naive, quote unquote, or they've never tried opioids before. And so they may be more sensitive to opioids than someone coming in with, say, a history of opioid use disorder, which may need higher levels of opioids to reach that analgesic effect. I think the biggest thing to worry about with these opioids is, of course, respiratory depression, and especially with a lot of the elderly patients that come in, they're more susceptible to these things. And so you really want to be careful in just reaching for something like a hydromorphone or an oxycodone in treating someone who's like 80 years old compared to someone who's maybe 30 years old. Oxy and hydromorphone and hydrocodone all have their different onset and time intervals of reaching that analgesic effect too. And so it's really helpful to think about how acutely you want to manage someone's pain, especially if they're having like an acute pain crisis and needing some faster acting agent compared to like a longer acting agent. So this is just a chart that kind of goes through some of these different analgesics and the formulations and kind of when to expect someone to feel some sort of relief after getting these agents. I just want to include these because they're increasingly being considered as part of someone's more like chronic pain management regimens. You'll hear a lot more coming up in your training about the use of buprenorphine patches, which has become a topic of huge interest in a lot of pain management teams. That's really effective in managing people with chronic pain because it's generally having lower risk of respiratory depression, has less GI effects, and also it's more convenient for patients to use too because it tends to reach a what we call it like a ceiling effect. And so it's a lot safer of using this in certain patient populations and requires a lot closer follow-up with a lot of primary care teams and managing this long-term too. And I also just want to mention longer acting agents like MS-Contin and OxyContin that are used for certain patients, especially those who have really severe chronic pain, like those who have really advanced cancers, or being used in the context of palliative care management, where they need this sort of more long-term, long-acting opioid treatment in managing their more severe pain. This is generally used in conjunction with other specialty teams, especially like palliative care teams, to help manage this. So I just want to include this so that you're aware that these agents exist, but expect that a lot of times you'll want to initiate this with the help of a specialty team like palliative care. And so kind of that giving that framework of approaching to pain, I think we can talk a little bit about one type of pain that you'll encounter really often in the inpatient setting, especially, which is abdominal pain. So imagine that it's admission day, you're on a really fun overnight call, and you get your first admit. But right when you're about to chart review that admission, you also get another page. So with the admission page, you get a 64-year-old woman who has a history significant for AML or acute myeloid leukemia, who's on chemotherapy here with 4 days of flu-like symptoms and worsening abdominal pain. But then you get a page from one of the bedside nurses saying that, hey, bed 23, which is a 34-year-old transgender patient, recently got bottom referring surgery, post-op day 6, suddenly has a rising fever, worsening abdominal distension, and 10 out of 10 pain. Please advise. So thinking about these two patients, they're very similar in that they have acute pain that they're coming in with, but they are very different clinical contexts and clinical stories. So when we think about abdominal pain, there's a lot of things that go on in the abdomen from an anatomical standpoint to a physiological standpoint. So where do you even begin with this? And so I think it's really important to think about all of these four main things that I came up with when trying to approach how to manage abdominal pain. Think about the anatomy, where the pain is located. Is it all over? Is it in a particular region? Go and examine the patient yourself. Do a really good physical exam, especially an abdominal exam. Try to look into their history. What has their symptoms been like? How long have these symptoms been in it for? Is this sudden abdominal pain that just showed up overnight, or have they had this abdominal pain for a while? What sort of procedures have they recently gotten? What sort of medications have they gotten? Are they even constipated? Things like that. And then when you're doing the physical exam, it's really important to figure out, especially as an upcoming intern, whether the patient is sick or not. Think about the acuity, and based on the acuity, that can also clue you into certain differentials with regards to abdominal pain, as well as where they're going to be. Are they going to stay on the floor? Is this something you can manage and just watch overnight? Or is this something that you need to page another service for, like surgery, for example, for more acute interventions? So framework is really foundational when approaching to abdominal pain, as it is for most things. One thing that I want to endorse is information from a website called the Clinical Problem Solvers, which has a lot of great diagnostic schemas like this one to help guide learning and thinking about a lot of these acute issues. So one thing that this really laid out nicely is the anatomy, thinking about the organs based on the different quadrants. For example, the right upper quadrant really is focusing on the liver and the biliary systems, thinking about inflammatory processes that could be happening, thinking about congestive processes that could be happening, and thinking about, from a biliary standpoint, stones, infections, inflammation, things like that. I think what's, again, going back to the acuity of things, thinking about what is potentially life-threatening. Are they acutely obstructed? Are you dealing with a perforation? Are they having a lot of peritonitic signs when you're examining them? And that can really help guide how acute or how fast you need to act on this and what sort of workup and interventions you have to do. Thinking about also things that may not necessarily fall strictly within the abdomen from an organ standpoint, thinking about referred pain from things like the cardiovascular system or the pulmonary system. People who have really bad pneumonia, for example, may have referred pain to like the upper abdomen, for example. Thinking about the renal and urological systems, thinking about distended bladder to like urinary tract infections to especially people who have ovaries, like ovarian torsion and endometriosis. So there's a lot of things, again, that could be happening in the abdomen. But if you follow a really systematic approach in terms of location, duration of symptoms, and the course of symptoms, that can really give you a lot of clues as to what you're dealing with. A lot of times when we think about abdominal pain, we reach for imaging to help guide a lot of our studies. So one of the things to think about is, could you do something like a CT or a KUB or an X-ray to figure out what's going on from a structural standpoint. If you get any sort of imaging that turns out to be negative, think about other kind of non-overtly structural things that are going on from like a metabolic standpoint to a toxic or other functional standpoints that may guide your differentials. Some of the examples of, say, metabolic things that could be going on is things like DKA, things like hypercalcemia. Medications are a huge iatrogenic effect on contributing to abdominal pain. A lot of times, for example, if someone's coming in with a pain crisis and you're trying to manage their pain, they may get really constipated, and that's probably why they're having abdominal pain. So again, thinking in terms of where it's coming from, how it's presenting to you, and using that to guide your differentials is really crucial. So going back to our first case, your admission case, which is that 64-year-old woman coming in with AML who's on chemo. She's here with 4 days of flu-like symptoms, worsening abdominal pain. And then you look in her chart and notice that her last chemo cycle was about a week ago. So fast forward to day 3 of her admission. She's getting worsened abdominal cramping. She's now having diarrhea. You check her temperature, and the last one charted is 101.2. These are the labs from earlier that day that you see. You can kind of type into the comments as to what you notice about these labs. From here, you can see that she's anemic. She's essentially pancytopenic, where she has anemia, she has neutropenia and leukopenia, as well as thrombocytopenia. And you're really prudent enough to check the differential of that CBC. And you notice that her ANC count, or the absolute neutrophil count, is 300, which is very, very neutropenic. And so you are astute enough to say, she's coming in with worsening abdominal pain. She's now febrile. She's also someone who has cancer on chemo and is very immunosuppressed. I want to order a CT to look at whatever thing's going on inside her abdomen. And this is the radiographic finding that you get. So these are just 2 different views of the same CT. And what do you notice out of where the arrows are pointing right now? Just going to take 5 seconds to see, just take a wild guess. Type in the comments about what you notice. And I know we're all going to IM and not radiology, so there's no wrong answer here from an IM standpoint. Yep, so Christine said stranding. Yep. So this is an example where the arrows are pointing, where there's just a lot of mucosal thickening, and quite a bit of stranding as well. And you're right, Aporia, that there's a lot of cecal wall thickening going on. And so this is an example of a really dire and really important finding to notice, especially in a lot of cancer patients, for a condition called typhlitis, also called neutropenic enterocolitis. And so you really want to suspect someone's coming in who's neutropenic, who has cancer, most likely a hematologic cancer instead of a solid tumor cancer, but can present in both. But the key thing is that they're neutropenic, that they're having a new fever, abdominal pain, especially happening about 1 to 2 weeks after starting chemo. And so with this, you really want to think about getting a CT to look at bowel wall thickening and treat appropriately with antibiotics at the very least. Okay, so that's that. So with inpatient hypertension, I want to just talk briefly about what do you do when you get that page. So say your overnight call, you get a page saying that someone's having a blood pressure of 173/98, please advise. And you'll always get a page ending with that comment. What do you do in that situation? So first, you need to assess, is this an emergency? Are there symptoms or are there no symptoms? Is this acute hypertension where they've never been hypertensive before, or is this chronic? So you really want to think about if this is what we call a hypertensive emergency, where the SBP is over 180 or diastolic blood pressure is over 110 to 120, or if it's asymptomatic. And now it's called asymptomatic elevated BP instead of whatever it was called earlier. Okay, so think about all these different factors that could be leading to higher blood pressure, from uncontrolled chronic hypertension to acute distress due to illness to certain medications that you're giving to them that may elevate their blood pressure, or if this is just stress due to being in a different environment than home. So, important question to really think about in terms of treating versus not is again thinking about the treatment course. Think about what the target blood pressure is, and how fast or how much should I order it? Should I lower the blood pressure so that it's in a safe manner? And generally, you want to reach for less than about 160, less than 100 in an inpatient setting. And really be careful not to drop the blood pressure too fast or too slow, because otherwise you would risk them being having things like a stroke, acute MI, or risk worsening hypoperfusion with end organ damage. And so there are a lot of different things that you can do to approach hypertensive emergencies when you do want to treat. Um, from things like hydralazine, where it's a very commonly used medication. And I will say with the caveat being that a lot of this may be dependent on institution and institution policies and what's available on the floor because part of this is nursing driven. Um, I think what's generally commonly used is hydralazine, which is a really quick and easy administration, especially from a nursing standpoint, where they can just give it and then monitor the blood pressure. Whereas things like nicardipine often needs a lot of kind of unit-specific capacities to administer this. So hydralazine works pretty well, but then you risk having kind of refractive tachycardia, uh, and also patients can tend to have like effects of flushing, headaches, and vomiting as well. And then I think labetalol is also, when it's available, it's a great choice to lower blood pressure too, because it tends to have less of the side effects that you would see with hydralazine. So in general, approaching patients with severe asymptomatic hypertension, for example, it's okay to really wait and monitor and recheck their blood pressure along the way. Thinking about what can be reversible in terms of what factors are causing their hypertension. And can you think about, can you give their next scheduled dose of blood pressure medications earlier than what's actually scheduled? But also importantly, just really think about and anticipate potential risks and what would happen if you don't act right now and their blood pressure continues to be uncontrolled throughout the night or the next day, and thinking about what their risk is in developing end organ damage. Okay, so in the final few minutes, I want to talk about how to manage insulin in an inpatient setting. Think about it in terms of a stepwise approach. First, figure out what type of diabetes that they have, if it's type 1 diabetes versus type 2, or if they don't have a history of diabetes, why they're getting hyperglycemic. Is this stress-induced versus some other etiology? For type 1 diabetes, every patient must have insulin at all times. This is just the rule. Depending on NPO or not, you can adjust the dose of the insulin that they have, but they need to have some sort of basal dose regardless, because they can have major fluctuations in their glucose throughout, and they don't have the ability to produce insulin in the first place. Figure out their diet situation while inpatient. Figure out what other people or team members you can involve in help managing insulin, especially if they come in with things like a CGM, for example. Is this someone you can involve pharmacy or endocrinology about in helping manage their diabetes? So the main goals is really to avoid hypoglycemia, and you do have some sort of leniency in an inpatient setting with a lot of like the extra stressors from an acute illness standpoint, to allow some sort of elevated glucose levels to an extent, but it's really to ensure that they don't have hypoglycemic episodes. So these are the types of insulin. I'm not going to go into detail about those just in the interest of time, but you have anywhere from rapid acting things like Lispro, Aspart, or glucine, to short acting like regular insulin, to longer acting like glargine, for example. So when you're, say, admitting someone trying to figure out how much insulin that they need, there is a more systematic approach for it. But in general, if they come in with, say, type 1 diabetes, you want to take their total weight is one general way of thinking about it, multiplying that by 0.4, and that's your total daily dose. From there, you want to split it into 50% of a basal dose and a 50% bolus dose. You can divide that bolus dose by the number of meals that they'll get. Typically, it's 3, so assuming that they'll have breakfast, lunch, and dinner. And then add an extra correctional sliding scale insulin to add to that bolus insulin. And you typically want to give like a lower correcting scale if they are underweight, if they're more elderly, if they've never taken insulin before. But you also want to consider higher doses, especially if they come in already very resistant to insulin and needing that extra doses to maintain a good glycemic level. So here's an example. You have a 60-kilogram patient who has type 2 diabetes. You want to calculate their total daily dose. So you can take like that 60 kilograms, divide it by half to get 30 units per day, and that's your total dose. From there, you want to determine your basal dose of insulin. So you take that and divide it by half, so you get 15 units of, say, Lantus. And then you want to figure out your bolus doses. So you take the other 30, divide that by half, and then by another 3, and then per meal, breakfast, lunch, and dinner. So you get about 5 units of short-acting insulin per meal. And so depending on that, you want to just see if they need an extra correctional sliding scale insulin, or SSI is how we commonly say it. And that should be kind of a general approach to deciding on an insulin regimen. Okay, so that's all I have. I'll turn it over to Tiffany for the next section.
Thank you so much, Ming, for such a comprehensive review. We're going to jump into the next topic, which is what to do in a rapid response situation for altered mental status. And you will get this page definitely overnight at some point. So here's an example. You are the night intern. You get paged that Mr. Johnson in room 412 is agitated. He's pulling out his IVs. It's 1 a.m. You're just cross-covering this patient and you've never met him. So what do you do in this scenario? So step one, the first thing is you always care about safety first. Are they safe? Are they stable? First thing is really safety. Is the patient safe? Are the staff safe? If there are safety concerns because of patient agitation, you immediately call security. You make sure you are safe. You consider physical or chemical restraints if there is an active safety concern. Then, once we make sure that the situation is safe, all staff are safe, there's no super violent things going on, then step two is what has changed? Is this a new confusion that's been going on, or has this been going on for several days and at baseline perhaps? And then step three, I argue actually this might be step two, my bad, is vitals, airway, stability. Generally speaking, if they're like super, super agitated, generally the vitals will be stable at that point. If they're stable enough to scream, they're probably not at risk of airway compromise. But if they're agitated and you're concerned that they are unstable in their vitals and their airway protection, call the ICU immediately. And as an aside, I want to note that delirium, which we're talking about here, can be hypoactive or hyperactive. So this case is the agitated delirious patient, but sometimes you'll get an unresponsive or zonked patient. And it's really the same workup and thought process for both. And when we're thinking about can't protect the airway, it's actually more relevant for the unresponsive hypoactive delirium cases. So the next thing that we can do is you can turn to the DIMES mnemonic here to think about what are the things that could be precipitating this delirium. Is it drugs? So new medications like benzos, opioids, anticholinergics, or steroids with roid rage? Is there withdrawal perhaps from alcohol, benzos, gabapentin? Is there an infection going on? And this can either be like a meningitis picture or it can be outside of the brain. It could be a pneumonia or a UTI or maybe some sepsis picture overall. Is there some weird metabolic component, like electrolyte disturbance or an endocrine issue? Is there anything going on with any of the organs that could be affecting their thought process? So are they having a massive MI? Are they hypoxic, hypercarbic? Are they accumulating a lot of toxins like ammonia? Do they have a uremia? And then we're also thinking importantly about environment. Do they have their hearing aids and glasses? Because if you think about it, if you are in the hospital, you're in this like new, completely foreign environment, and then you wake up oftentimes I wake up and I'm like in a hotel and I'm like, where am I? Think about the patient who's already at high risk of delirium, and now they wake up, they're in this foreign environment, they can't see, they can't hear, they're not in their own bed. It must be really confusing. So that can also cause them to be agitated. So we have to think about sensory impairment and, lines, tethers, restraints. Is their sleep-wake cycle optimized? How do we optimize their environment to be as close to the home setting as possible? Then there's structural considerations. So is there a brain bleed? Structural being like what anatomically could be going on. Inside the brain, it's usually bleed, stroke versus seizure. And then outside the brain, is there constipation or is there bladder retention, acute urinary retention? Is there some undertreated pain process that's going on in the body that's causing them to be delirious? Those are things that I'm thinking about on the back end as I'm trying to figure out what could be going on that's causing this agitation. So you go and assess Mr. Johnson, and you go to the bedside, you're looking through the vitals. Vitals look, I mean, tell me if anything jumps out, but relatively stable, I would say. A little bit tachycardic, which is expected because he's agitated and flailing. A little bit hypertensive for the same reason. Normal work of breathing. He winces when you press on his belly. And then you get the picture that last night he was pulling his IVs as well. So last night was really the same picture, but you weren't on last night. He was tugging at his Foley. He did not sleep. He hasn't had any bowel movements for 3 days, and he has been lying in bed the entire time. Pretty common story. The only other notable things on labs are that the CBC was normal, BNP was normal, but the point of care glucose was 53, so a little on the lower end. So the bedside assessment is really critical here. The immediate things that you must do, kind of back to the step one back there, safety first and then stabilization. So immediate, if there's any ABC concern, airway, breathing, circulation, any of these things, you call the ICU immediately. And the first response things, if you come to a patient who is like completely zonked out of it, first things you do in the RT situation are oxygen if they appear hypoxemic, glucose if they're hypoglycemic, naloxone if there's concern for opioid overdose. So actually, I just kind of memorized this as its own mnemonic. DIMES is what I'm thinking as my mnemonic for like, okay, what else could be going on as I'm running to the bedside? Once I'm at bedside, I actually go through A, B, C, OGN. So A, B, C, and then oxygen, glucose, naloxone. Then I do the physical exam and I'm thinking, okay, are there any focal deficits? Do I need to call a stroke code? Are they alert and oriented? Do they know where they are, when it is? Ask the nurse about bowel and bladder if there's anything else going on. And as a quick aside over here, we're thinking about delirium here, and the definition of delirium is you have to have 1 and 2 and 3 or 4 that are listed over here. And the hallmark things that 1 and 2 that you need, they're inattentive and it's acute altered mental status that is fluctuating in picture. And then at bedside, I'm asking the nurse, okay, can we draw a CBC, a BMP? Can we get a point of care glucose? And then if there is suspicion for, let's say, like hypercarbia, ABG is never a bad idea. If they have a cirrhosis history, think about hepatic encephalopathy. Are they moving their bowels? Check their ammonia, perhaps. Check their LFTs. If there's an ingestion or drug overdose concern, definitely UTOX, and then do a general workup for infection. Chest x-ray, UA, blood cultures, things like that, especially if they appear septic or their vitals are off. And then if you're concerned for focal neurodeficit, then it's a stroke code and you get a stat head CT. The big thing, though, is I wanted to bring it back to DIMES because generally speaking, once we have done all of the stabilization, we've covered the ABCs, we give them oxygen, glucose, naloxone, whatever they need in that acute setting, we've sent all the rainbow labs off. Oftentimes, all of those actually end up being roughly normal. So then it's really about addressing all the underlying issues and the unmet needs. So we're going to go through DIMES one by one and basically optimize their drugs and their med list. We're going to go through and double check to make sure that we're treating and evaluating for infection, removing all lines and drains like Foley's that can contribute to infection. Any metabolic impairments and derangements, we're going to treat the underlying thing. And the environment, it's all about reorienting, reorienting, reorienting. Before you jump to that Haldol, before you jump to the olanzapine, unless they are a safety or risk to themselves or others, the big thing is really going to be non-pharmacologic management, and that is evidence-based. Reorientation is going to be the key thing with focus on sensory impairment, sleep, trying to let them get their sleep because otherwise we're just making them more delirious, and then removing all tethers and restraints as able. And then, of course, under structural, we need to treat the pain, we need to treat the acute urinary retention and constipation, make sure they're eating right, making sure they're mobilizing, basically getting them back to their homeostasis. All of these are unmet needs that are not being addressed properly. So for Mr. Johnson, kind of already mentioned some of the things. He has abdominal pain. He's asking, where's my wife? He's hypoglycemic. These are things that make him already very high risk for delirium, precipitating and predisposing factors. He has a Foley. He hasn't been sleeping. He hasn't pooped. He hasn't been mobilizing. And these are things that I'm thinking about. But once you get to a point where you absolutely do need medications, again, I want to stress that non-pharmacologic management is going to be the mainstay. But if you do need medications, the safest one that we usually consider is trazodone. Trazodone, again, there's not terribly much studied regarding any of the antipsychotics or any of these medications because the approach to delirium is truly mostly focused on non-pharmacologic management, but only if there are safety threat to themselves or others, and we absolutely need something for all of this. Then we would do trazodone first in green, and then all of the orange ones are kind of along the same line of like use with caution. Antipsychotics. All antipsychotics do carry a black box warning for older adults with cognitive impairment. And then in red here, basically the benzos, Ativan is our most commonly reached one. We tend to not like antipsychotics as much, but we really, really don't like benzos, especially because it can cause agitation in older adults. And for all of these, the principle is to start slow and go slow. Do not dose stack. So this is one of those things where, again, you only give it if they're at risk of harming themselves or others, and you need to give it like 30 minutes to 60 minutes for it to actually act. So if the nursing staff is asking you like, hey, can we get another Haldol dose? Can we get another Haldol dose within like 5 to 10 minutes? You say no, we got to give it a little bit of time first. Um, there we go. Okay. And then of course, no antipsychotics if they have any concern for Parkinson's or Lewy body. That's the other main thing that I wanted to highlight. All right. The next thing on the docket, hypotension. You're on the floor, you get an urgent call. Doc, the patient's MAP is 57. You're running to the bedside. First thing, is it real? You need to double check to see, is the blood pressure measurement actually correct? Is it the right cuff size? Are the leads on properly? Are the vitals actually being properly checked? And then the next thing is, of course, you go to bedside. You assess the patient. Same thing here. ABCs. If there's any concern about airway, breathing, circulation, if not normal, you skip directly to the last step, which is going to come up later for ask for help. You start developing your gestalt and internia of, is this patient sick or not sick? So basically, do they look like they are going to crump any moment? And if they do, you ask for help immediately. Then you're looking for, if they're hypotensive, signs and symptoms of hypoperfusion. Is the hypotension causing end organ damage, which is reflected often in change in mental status, decreased urine output, slow cap refill, and poor extremity filling? And if you have a POCUS, it's a great opportunity to practice those skills because you can take a look at the heart, see if it's pumping properly. You can take a look at the lungs, see if they're filling with fluid. You can do a fast and make sure they're not bleeding out. So POCUS is a really valuable tool for this that I encourage you to use. Then you are called to this rapid response. You don't know who this patient exactly is, but you've already gone through like sick or not sick, do I need to ask for help immediately? After you've stabilized and made sure that there's no super acute things for which you need the MICU there immediately, then you go to the bedside workup, you review the chart. What was the last one-liner? Are they on anticoagulation and potentially bleeding out? You go through the MAR. Did they receive any medications? Oftentimes it's actually this. Did they receive any medications so that we cause them to be hypotensive? So I'm thinking blood pressure medications, diuretics. I'm thinking if there's any reversible causes to this. So what does that mean? Basically, did we do this to them? Is there something else that's going on? Did they just have an operation? Are they on propofol? Is there anything else that is going on in the background that could be contributing? And then I'm looking at the last echo to see if there could be a cardiogenic or obstructive component in all of this. And I'm asking the nurse, of course, to just draw rainbow labs. So as you'll start hearing a theme in this, for all rapid responses, the bedside workup for rainbow labs oftentimes is very similar. You'll get a BMP and CBC. For hypotension, you'll get a lactate to double check for like hypoperfusion and organ damage. ABG, VBG is never wrong. If you're concerned about heart issues, then check EKG, tropes, BNP. If you're concerned about like sepsis or infection, then it's time to get a blood culture, UA, chest X-ray. Then you have to, again, if you went to assess the patient and they were already decompensating, you ask for help immediately. So skip all the bedside stuff and go straight to ask for help if that's the case. If the patient is decompensating, it's never wrong to get help early. It's never a wrong thing to call an RRT to get all hands on deck. And then you can escalate to your senior, escalate to your attending, call the MICU and step down, call all applicable consultants if you need IR for a possible thrombectomy, if you're suspecting PE, if you need cardiology because you need to activate the cath lab because they had massive MI, things to think about in the back burner, but call for help. And then as you're waiting for the help, you're going to make sure, one, that all of those rainbow labs that we just discussed before are drawn. You're going to make sure, especially if you're concerned about bleeding, that they have 2 large bore IVs and good points of access. You're going to resuscitate with fluids or blood. If you suspect that they're bleeding out, and that's the story that the history is giving, then go ahead and just resuscitate with blood. Otherwise, you can do crystalloid, like 1 liter LR wide open, or NS, but I prefer LR. And then we think about source control, empiric antibiotics. Are they septic? We hold all of the offending medications like antihypertensives, and then we just keep reevaluating. Do we need more imaging? Do we need more labs? But at that point, you're kind of hitting the tail end of the RRT. People are gathered, more people have an idea of what's going on. Ideally, primary team is there, can weigh in on what the story has been. But these are the acute things that when you go to an RRT for hypotension, when you don't really know the patient, these are never a bad idea. All right, on to AKI. So the reason we decided to cover AKI, sometimes you'll be admitting a new patient overnight, and you're the intern. Patient you note has acute decompensated heart failure. Cardiology has been titrating diuretics, let's say, but she's coming in because she's up 5 pounds over the past 2 days. She's feeling a little short of breath, and creatinine on admission is now at 1.8. Baseline is 1.1. Ding, ding, ding. That should clue you off to something's going on. There's definitely an AKI here, and 1.1 and 1.8 is actually a pretty big jump, so I want you to be concerned about that. But then the question is, as you're admitting, well, what do you do with this AKI? So step one, is this an AKI? The first thing to note is AKI definition is basically these things. So acute kidney injury, we're looking at the creatinine cutoff, and we're also looking at UOP criteria, urine output. But the big thing is, even if it's just 0.3 of creatinine bump, that classifies you as a stage 1 AKI. So it just needs to be up by a little bit over 0.3 or 1.5 to 1.9 times baseline. And that reflects a fair bit of decrease in renal filtration function already. So once you confirm that you do have an AKI, the next thing you're going to do is you're going to go assess the patient, you're going to do an HMP, and the biggest thing next is you're going to assess their volume status. The reason why the volume status is important is because 9 times out of 10, really it's a volume thing. The classic teaching is you check your eulite, you see if it's pre-renal, intrinsic renal, post-renal, and I still think that's a helpful framework, but when you are the admitting intern, the big thing that's next for you is actually volume status. So for example, if you get sign out for an acute decompensated heart failure patient overnight, and the day intern tells you like, follow up the BMP at night, follow up their creatinine, follow up their K. I think that's very fair, but also ask them, like, what is the net I&O goal? What dose of diuretic are they responding to? When was the last dose? Because most of the time, if they do have an AKI and it is a hypervolemic thing, it's the volume status will actually tell you what you need to do to manage things going forward. And having asked that history will help. All right. Based on the volume status, then, right after that, you're going to assess volume, meds, obstruction. And this roughly lines up with the pre-renal, intrinsic renal, post-renal schema you've already heard of. But common things being common, again, it's usually a volume problem. So you might jump to order urine lights, but it's actually not that helpful. In reality, AKI is usually multifactorial. The FeNA and FeUria don't necessarily trump your clinical gestalt, and there's a great like things we do for no reason article on that. But you can have pre-renal AKI with FeNA less than 1%, and FeNA less than 1% could either reflect too little fluid or too much fluid on board. Too little fluid, your kidneys are freaking out and releasing RAS anyways. Too much fluid, like acute decompensated heart failure, the heart can't pump forward, the kidneys are seeing less effective circulating volume, and the kidneys are still freaking out, and therefore you have an AKI. So if you wanted to distinguish like pre-renal versus intrarenal, you would have some history, usually of like contrast or some insults that caused an intrarenal thing, like ibuprofen use, etc. So even if it's ATN, FeNA doesn't really change your management because you still would either bolus if they're hypovolemic or diurese if you feel like they're hypervolemic. So really checking FeNA versus FeUria, it doesn't really help us figure out what we're going to do next. So the big thing I want you to think about actually is then volume first. Are you volume up or volume down? If you're volume down, baby bolus. If heart failure, but you bolus. If you think they're volume up, you diurese more. And then you reassess the creatinine every 6 to 12 hours. You see where you got. If it got worse, you do the other thing. So a lot of this is going to be oftentimes relying on your clinical gestalt. Fluid exam is one of the hardest things in internal medicine. And then using your tools, your physical exam, your POCUS, those can all give you a sense of what their volume status really is. Um, so reassess. But if you really look at them and you think, hey, maybe they're like euvolemic or you're really not sure about their volume status, then at that point, maybe it's helpful for you to get the urine lights and then see, are there medications that are contributing to this? You hold for all cases of AKI all the offending agents, NSAIDs, ACEs, ARBs, diuretics, all nephrotoxic antibiotics, contrast, and then we want to renally dose all medications like gabapentin and things that are renally cleared. And at that point, then it's probably time to get nephrology on board. They're euvolemic, so we don't think it's necessarily a volume thing, but nephrology can help us figure out like, is there something else that's going on, like ATN, AIN, is there rhabdome? So UA is usually helpful for that. They often ask if there's any new meds that were started. And then if we're really at a loss and we can't find the culprit, the nephrology is usually on board when we start thinking about biopsy. But if it's one of those cases where it's like ATN picture or AIN picture, intrarenal basically, then we fix the underlying and we provide more supportive care until the kidneys recover. And then, of course, obstruction, the last category here. You'll have a history that suggests this. They either will have a history of kidney stones, mass, BPH. So basically just bladder scan them. And if they have a Foley in place, double check to see if it's kinked. The fix is to basically fix the obstruction. And you can always get a renal ultrasound for hydronephrosis if you're not sure. Here we go. Okay, so the action plan summary. Call your senior now and escalate the situation if they have a stage 3 AKI, which is that the creatinine is greater than 3 times the baseline or greater than 4. That's basically bad, bad, bad. We might need urgent dialysis. If there's hyperkalemia greater than 6 or EKG changes, immediately contact them. Contact nephrology, call your seniors, call MICU because they actually might need urgent dialysis at that point, especially if they have EKG changes. If they have oliguria, despite intervention, you've already given them the usual bundle of things. You've done all the temporizing measures. Let's say if they have hyper K. If they have metabolic acidosis, pH less than 7.2. If they have bicarb less than 12, all of those things are things that would ring my alarm bells for maybe they might need MICU now. If they have pericarditis, encephalopathy, bleeding because of uremia, or if you're just really not sure what to do and you don't think it's really like necessarily a volume thing, it's never a wrong thing to ask for more help. And then your next steps, you're going to get your BMP, UA, and micro. If you're concerned for HRS, you can get urine lights, but otherwise, again, usually just refer to your volume status first. You're going to examine the patient, you're going to stop all the offending meds, rule out obstruction, and then fluid resuscitate if dry, diurese gently if overloaded, and then reassess. And that's basically your nighttime plan for AKI. All right, next thing. Decompensated cirrhosis is a really, really fun topic. I've talked to Ramya at length before about how much we love the liver, and even though none of us are going into hepatology, I think, um, it's just such a cool organ. And this image here, Curbsiders made this brilliant diagram to help us understand exactly like how we think about the different factors that feature in cirrhosis and liver dysfunction. So, as a review, cirrhosis means you have a hard liver, basically. And decompensated cirrhosis, all the complications either come from basically portal hypertension or liver synthetic dysfunction. So, when we're thinking over here, first of all, blood flow to the liver is shot, and you have this hard, rocky liver. So then it all gets backed up, and you get portal hypertension, and therefore you get varices. Along with that, the gut is freaking out because you have too much pressure all backed up in that splanchnic system, all in the gut circulation. So then they start doing some splanchnic vasodilation. And because of the splanchnic vasodilation, you get hypotension, leaky vessels. And because of the leaky vessels, you're also a much higher risk of spontaneous bacterial peritonitis. The kidneys are starting to freak out now also at all of this hypotension that it's seeing. And then it's saying, we got to activate RAS. We have to retain sodium, retain water because we're hypotensive. We're seeing too little fluid. We must be losing fluid somewhere. And then this is a really bad cycle because as we're retaining more fluid, it just makes the portal hypertension worse. So then all that fluid has to go somewhere. With all the leaky vessels, now it's going to third space into our ascites. So now you're basically fluid overloaded, your kidneys are freaking out, your portal hypertensive system is freaking out, and everything gets third spaced. And then along with RAS, you also get renal vasoconstriction because the kidneys again are freaking out. They're like, we got to retain more, and that renal vasoconstriction can lead to HRS, which basically looks like a pre-renal AKI, but it doesn't respond to a fluid challenge. So that's everything that's related to circulatory dysfunction as a result of portal hypertension. Now, at the bottom here, now I want to point out what can go wrong because you have liver synthetic dysfunction. So the way I think about it is liver function is broken. Function number one of the liver is we clear ammonia. Now we can't do that, so then we get hyperammonemic hepatic encephalopathy. So they're super confused, they're zonked, and that doesn't make it any easier to care for them. And then function number two that the liver does is it also makes our coagulation factors. So if you can't make your coag factors, you get coagulopathy. And the tricky thing is you're at increased risk for both bleeding and increased risk for clot. So both of these, it's a double whammy and it's bad. When I'm thinking about admitting a patient with cirrhosis, how do I manage it? I go through the VIBES checklist. So, what does VIBES stand for? V, I gotcha. You thought it was varices, didn't you? But V is actually volume in this case because varices falls under bleeding. Volume is one of the key things for cirrhosis complications. And it basically refers to the fact that when you have cirrhosis and you've got all of this third spacing, you've got this ascites and portal hypertension, your volume's kind of out of whack. And your volume balance is a little tenuous because you're at once intravascularly volume depleted and hypotensive, so the kidneys are seeing too little volume, but you're also volume overloaded everywhere else in the extracellular space. So in order to fix this, we have to sodium restrict. We give diuretics like Spiral and Lasix. We do a paracentesis, large volume for therapeutic effect. And then we do a TIPS if it's really severe portal hypertension to which they're having volume in their lungs, super, super uncontrolled ascites. These are things that we can think about for, these are things we can think about. Yes, thank you, Spenser, Gen Z mnemonics. Things that we can think about to manage the volume when someone comes in with the cirrhosis complication of hypervolemic dysfunction. The next thing to think about is infection. If you have fever, abdominal pain, AMS in a cirrhosis patient, it's SBP until proven otherwise. The criteria is you do a paracentesis and the PMN's count is greater than 250. So I want to emphasize how important it is that you get that paracentesis because if you are the night intern admitting this patient, if you have started them on antibiotics already, unfortunately, after that, it's too late for you to check if they met this cutoff. So you have to get the if safe to do so, ideally overnight, you should get that diagnostic paracentesis, at least to send it off before you start the antibiotics. But again, you need to start the antibiotics too, so it's a really time-sensitive thing. If you absolutely can't find a safe pocket for a para, I would rather you give the antibiotic because they absolutely need it. So you treat with ceftriaxone for 5 days, And then after they've had one episode of SBP or they've had prior GI bleed and they're at high risk for SBP, then they will need lifelong prophylaxis against SBP with either Bactrim or Cipro. Bleeding is where we're thinking about varices. So for bleed, resuscitate first, obviously. So if they are bleeding out, variceal bleeding is a nasty thing. It's violent, violent bleeding. People have hematemesis. Um, it's like blood everywhere. So just so you know, like we don't F with variceal bleeding. You have to resuscitate as fast as possible. You make sure they have two large bore IVs. You get GI on board immediately to band the varices. And then if they do have varices that's found on a screening EGD, then you need to prevent it with either carvedilol or propranolol. For encephalopathy, you target the BMs per day, 3 to 5 per day. You use lactulose, Miralax enemas, start rifaximin if you need, and then you got to screen with like AFP ultrasound Q6 months. And that's it for my section.
Thank you, Dr. Hu. That was very informative. We're actually going to take about a 9-minute break. So if you're in the West Coast, that'll be about 3:10, and y'all can adjust to y'all's time zones. But we're just going to stay on this slide. Feel free to put questions in the chat in the meantime. The speakers will answer it whenever we get back to use the chat. And y'all can feel free to use the restroom, take a snack break, walk around. But yeah, we'll be back in 8 minutes. So bye bye. Y'all can stay on this thing, by the way. I'm just saying we're gonna take a break. Actually, I forgot to say something too. I'm also going to put a link in the chat really quick. At the end of this thing, we're going to provide a survey, and also now we're going to provide a survey to see what y'all liked about our bootcamp series so far, and if you have any constructive criticism for next year's bootcamp, so we can make this even better. What did you like about the presentations? What do you wish we could have delved upon? It's all on the survey, which I'll be sending out, but please fill it out when you can. We will provide a copy of these slides after the recording, only if you fill out the survey and you leave your contact information below so we know who to send the slides to. But that is it. See y'all in 7 minutes. All right, everyone. It's been some time since we just got back. So we're going to go ahead and pass the mic off to Dr. Sampath. She's going to get us started. Let me share my screen and I'll hand off control to her.
All righty. Thanks everybody for staying on board with us. We have another fun-filled about an hour, I think. So we're going to get started. That was a great segue from Tiffany's topics about cirrhosis and bleeding to talking about GI bleed. So the number one thing that I hope that after this boot camp that you take away, we're always asking the question, are they stable or are they unstable? No matter what the condition is, really that's the essential question. And so here, the purpose of this figure is really to help you ask, okay, well, what do we need to do if the patient is unstable? Because we're going to be delaying some of our diagnostics. We're delaying thinking about, well, how do we localize the bleed? And really, we're just thinking, let's get them to not have more horrible complications from massive hemorrhage. So, like with any emergency situation, we're starting by thinking about our ABCs, the airway, breathing, circulation, making sure that all of that is not being compromised by their current hemorrhage. And so, specifically thinking about airway, this is you might not think airways can be compromised, but especially if someone has a lot of hematemesis, that unfortunately can be a source of compromise. And so, we're always thinking about those things. And then large bore IVs, we're going to talk about in a second, but that's always part of your GI bleeding algorithm. And then making sure that they're on telemetry, making sure that their vitals are able to be monitored. And in all cases, being able to alert the relevant people who need to help. And so in a lot of institutions, this may require a higher level of monitoring. If there's a person who is unstable and bleeding, your institution may be able to take them in a step down unit with frequency of vitals monitoring, or they may need to go to the ICU. And so always being aware of what your institution's protocols are with regard to certain situations and frequency of monitoring is of the essence. Now let's talk about then what happens once you've stabilized the patient. That patient is doing great. They went to the MICU. They're doing fine. GI's on board. They were called. Okay, so now what about the patient who maybe you have a little bit more time? They're not unstable. You answered yes to the question, is the patient stable? So we have a little bit more time to try to differentiate between causes. So now we're thinking about how do we actually identify what region this bleed is coming from. If you remember, we're thinking about the ligament of Treitz as being the place that demarcates what constitutes an upper GI bleed versus a lower GI bleed. You're going to see with upper GI bleeds, you might see symptoms like hematemesis, so like vomiting up blood. You may see melena, and in a second, we're going to have some ugly pictures of blood in stool, just so that everybody's clear what it looks like. And then there's an asterisk here that if you have a very brisk upper GI bleed, you may also see some bright red blood per rectum. But again, that might be in situations more like a variceal bleed. Again, really brisk, really massive. We don't F with that. Now, other things that can cause GI bleed other than that scenario, things like any GI tract damage, so mucosal irritation like esophagitis, GERD, ulcers, peptic ulcer disease, things like that. As well as gastric cancer. And then any blood-related disorder where you have an increased propensity to bleed can also start to bleed from those kinds of friable lesions. And then thinking about lower GI bleed, this is where we more commonly see blood, like frank blood in stool or bright red blood per rectum. You're going to always be using your differential for what your patient demographics are to help you guide what etiology do you think is most likely. And so for a 40-year-old, you're maybe less likely to think that diverticulosis is a cause of their bright red blood, although perhaps not impossible. But in an 80-year-old, you might think, okay, well, this could be a diverticular bleed. You're also going to be thinking about colon cancer and then intestinal ischemia, as well as hemorrhoids. So these are some of the very common things that you'll see as etiologies of bleeding. There are uncommon things that we're not going to talk about. And then thinking about what patterns might you see. BUN to creatinine ratio of greater than 36 is not a sensitive sign, but it is actually quite specific. So it's great for ruling in a bleed. It has, I think, about a 98% specificity. Things like hyperactive bowel sounds, the reason we might be thinking about that with an upper GI bleed, or it might tip us in that direction in a patient that you're already thinking about, is that blood is a cathartic agent. So it's very irritating for the mucosa. And so if you're hearing a lot of hyperactive bowel sounds and you haven't yet seen a bowel movement, but maybe you're concerned that you have melena, that can be something that you're thinking about. And then of course, if you have a patient with an NG tube and you're aspirating blood, you're more likely to think that that's going to be an upper GI source, blood pooling in the stomach, perhaps in the esophagus, perhaps coming from the stomach. And you're able to suction that up. Now, I believe my next slide is my picture of stool. Yes, there it is. Okay, so my whole point of this is just to really show you what do bloody stools look like. If you get paged about bloody stool, the number one thing that you really need to do is look at the stool, whether that's directly in person or with a picture. So, let's say you get paged, this patient is a 30-year-old patient and they have the stool in the right-hand side picture. So it's bright red, it's pinkish toned in the toilet. So this is blood mixed with water. This is something that is going to lead you to think, okay, I'm more likely to think this is coming from the lower GI tract because I'm seeing frank blood. Whereas this person on the left side, this person has been consuming a lot of Advil every single day because they have knee pain and they're taking like 2,000 milligrams of ibuprofen. And now I'm thinking, okay, well, that looks pretty melanotic. For those of you who have not seen melanotic stool or smelled melanotic stool, it can be very malodorous. It is very strong. Often, and it can have a pretty recognizable metallic and strong scent. But these kinds of signs will also help you try to identify what source of bleeding could this be. Okay, and then, oh no, wait, come back. Okay, so then what are we doing about it? The number one thing I put up here is DCAC, like discontinue anticoagulation, because if the person is bleeding in the setting of anticoagulation, that's something that in most cases, it does not need to be uninterrupted. Obviously, you'll think about the specific person and the specific case, but don't forget to be looking at what their medications are that you might need to hold or modify in the setting of their bleed. Then we talked about large bore IV. This is just to remind you of your basic physics principles, in which resistance is inversely proportional to radius size. And so the smaller the radius of your IV, the higher the resistance is going to be. And so this is why we talk about large bore IV. So that means technically 16 or 18 or higher, because in this case, you can do, for example, in a 14 gauge, you can do a liter in less than 4 minutes. Whereas in a 22 gauge needle, you can do a liter in about 20 minutes, which that doesn't sound like a huge difference, but for the patient with the variceal hemorrhage who's hemorrhaging out, that can be a difference between life or death. And so that's why we care about gauge. That's why we talk about large bore IV. And then you're doing all of the resuscitation things. You're making sure that you're getting a type and screen if the person doesn't already have one. This is so that the blood bank can cross-match their blood. If a person is requiring more than 4 units of blood within the first few hours of the episode in which they need blood, then you might consider asking for a massive transfusion protocol, but different institutions have different rules around that. I also circled the antibiotics and octreotide specifically for the cirrhosis population that Tiffany already talked about a little bit. And then if you're worried about an upper GI bleed, you're going to be starting IV PPI, which in most cases is going to be pantoprazole or lansoprazole. Then at this point, you're probably calling GI if you're concerned enough that you need to be starting all of these medications, you're calling GI so that they can decide what the appropriate management will be, what the appropriate diagnostic tool will be, and if they can actually put those two things together, like they can visualize and band or visualize and treat, that's great. They might also advise you to call in other friends like interventional radiology and obtain other imaging. But some of these methods, again, none of these things are going to be things that you're likely to do as an internal medicine resident, but just useful to know about going into it. And then next, we're going to be talking about one of my favorite topics, which is chest pain or ACS. So we're really focusing here on acute myocardial injury that is ischemic in nature. And so the reason I tease that out is because that is what we consider a type 1 or type 2 myocardial infarction. There are many other causes of myocardial injury. There are also many causes of non-ischemic myocardial injury, but we're specifically focusing on the heart attack type, the MIs. So I apologize if this is very small text, but really I'm just calling out that we're talking about type 1 and type 2 MIs, not these other types, which I didn't even know existed until pretty recently. In these cases, what you're thinking about is plaque rupture that has then aggregated platelet formation around it, which is why antiplatelet agents are so essential in the management of type 1 MI. In type 2 MI, what you're thinking about is really a mismatch and a mismatch between supply and demand, which can also coexist with atherosclerosis, but it is not the primary mechanism, is not the atherosclerosis or a plaque rupture. And so most of the guidelines that we have at this point thinking about MI are primarily focused on type 1. And so for those of you who have learned the monobash mnemonic, we're going to go through it. It's actually still fairly evidence-based, so we'll go through that. But again, with all of these things, the first set of questions is this patient stable or not? If they are not stable, then you are going to be doing a little bit more than what we're going to be doing here. You're likely going to be consulting an ICU. You might be already consulting cardiology, especially if you're worried about things like blood pressure. But let's say that we have a patient who's coming in with chest pain, vitals so far seem pretty stable, and they are giving you a history that is telling you they have pain on exertion. It's been less than a week. They have chest pain on exertion. You get an EKG, and you're not really sure what you see on the EKG. And it's not just because you're a fresh intern, it's because the EKG shows us some T-wave inversions. It doesn't necessarily show us ST depressions or ST elevation. This would be something that you could see, or you could see no changes. But then you also get troponins, and the troponins are elevated, and they're elevated beyond what you had previously seen this person having. This is a person that I would be worried about with their story and with their EKG changes. I'd be worried about an NSTEMI, which would be something that is a partially occlusive thrombus, that you don't have evidence that there's a full coronary occlusion, but this is a type of ACS, as well as unstable angina, which the difference between unstable angina and an NSTEMI definitionally is that in unstable angina, you don't necessarily have myocardial injury evidence yet, but you're worried that could develop. And then with a STEMI, as you all know, we're worried about ST elevation, and this indicates a transmural ischemic injury, and that's why we are most concerned in a lot of cases about this, of getting this person to the cath lab as soon as possible. The door to balloon time that we still recommend is less than 90 minutes from EKG to cath lab, and I think that actually now less than 60 minutes is the current desired recommendation. In all cases, if you are worried about a patient who has a troponin elevation that is dynamic, so this is not just any troponins that this person has ever had. There might be causes of a person having a troponin elevation, and it's always been somewhat a little bit elevated. They don't have symptoms. That's not a person I'm worried about. But the person I'm worried about is somebody who has not really had a lot of troponin elevation before. They have active chest pain. They have chest pain on exertion, and now they're coming to you and saying, I'm worried about my heart. There's going to be a lot of nuance there, but that's somebody that you should call cardiology for. They will ask you for the EKG. They will ask you for some of this basic information, and then they'll take it from there. We'll go through a little bit of these non-cardiac etiologies in a second, but I just wanted to get to this monobash mnemonic. I've highlighted in red the things that are really essential for every patient who you're worried about with a STEMI. That is going to be antiplatelet, that's going to be anticoagulation, and that's going to be statin. With the statin, that would be a high intensity statin plus any additional lipid lowering agents that would be required to get them to less than 70 on their LDL. Other things, the morphine and the nitrates, if the patient is symptomatic and they're able to tolerate those things, then absolutely. If a patient has an oxygen less than 90%, then you can give them oxygen. But those are sort of on an as needed basis for that patient. And then the beta blocker, why it's there is to reduce myocardial demand. In a patient who's not able to tolerate that for heart rate reasons, you might choose to skip that. And then an ACE inhibitor, particularly in patients with diabetes, hypertension, and EF of 40% or less, that's the population that and who doesn't have necessarily a contraindication like an active AKI, those are the patients that you're really very eager to start an ACE inhibitor on. And then I just want to add to that serial EKGs, because these things evolve, they develop, and they change. And so being able to see those things develop in real time is very important. Being able to track vitals to make sure we're not going from stable to unstable, and making sure that we're getting labs to be able to quantify any sort of impact on other organs is essential. And then I just wanted to go back to this to talk about how even if it is a not ischemic cardiac etiology, there are many other dangerous causes of acute chest pain that are not just cardiac ischemia. And so being sure that we're not missing something like a PE or aortic dissection or even myopericarditis as part of a larger systemic constellation is very important. Okay, so then acute decompensated heart failure. We're just going to go through the big thing that I wanted you to take away from this slide is not all of the categorizations, the HFrEFs, the HFpEFs, all of that, but rather that acute decompensated heart failure is a clinical syndrome of symptoms due to hypoperfusion and congestion due to the reduced cardiac function. And so it's a clinical set of syndromes. It's not something that you can, look at an X-ray and say, oh, this person is in acute decompensated heart failure, though in the right person with the right history, you might make that conclusion. So broadly, we can think about heart failure symptoms as being divided into these major categories of forward failure and backward failure, which are just colloquial ways of talking about decreased perfusion and congestion. And so decreased perfusion means decreased perfusion to the brain that would cause things like altered mental status or fatigue, or decreased perfusion to other parts of the body that could cause poor appetite, anorexia, and weakness. Whereas the congestion is more often what we think about as being heart failure symptoms, with the lung findings, with edema, with shortness of breath, with satiety and bloating. Very quickly here, most of the patients that you're going to see on the floors are going to be the patients who are in the warm and wet category. If they are cold and wet, you're really worried about cardiogenic shock in this case, and that is a person who needs to go to an ICU likely, or at least receive other stabilization. But for the average patient that you see come in, maybe they have heart failure that you already know about, and they didn't take their Lasix for 3 days. And now they're coming in after also having Thanksgiving dinner, a very, very salty meal. Now they're well perfused, but they're coughing a lot and they have shortness of breath. That person is a person I'd put in the warm and wet category. They likely have increased JVP, which is why we're always looking at that. We're always looking at whether they also have other signs of organ dysfunction, for example, an AKI, as Tiffany mentioned, that can absolutely be due to increased volume on board. Another quick mnemonic that has 2 A's and 3 I's with failure. This is really just a way of structuring how you think about systematically why did this person become decompensated? If this person previously had heart failure, Why are they now presenting in decompensated heart failure? And so not forgetting to look at etiologies that might help you explain that. So making sure to get your CBC, making sure to get an EKG on this person, making sure that we don't need to worry about ischemia as a cause of acute worsened heart failure. So absolutely checking out any sort of related organ dysfunction. In terms of the acute workup that you're going to be doing, primarily we're thinking about, as we said, CBC, CMP, NT-proBNP to help quantify how stretched are these atria, lactate for any evidence of shock. And then if the person has if the person has angina or any concerning signs that they are actively having ischemia, then getting a troponin can be valuable. You're going to be looking on imaging for signs of pulmonary edema, pleural effusions, cardiomegaly. And on EKG, as we mentioned, you're looking out for any new signs of ischemia that the person has not previously had, any new heart blocks that can precipitate a heart failure, and any sort of low voltage findings. Then on that you're also going to hopefully be very skilled at POCUS, especially in this generation of medical education, and you may be able to detect there any sort of precipitants, like structural causes for why this person is now in heart failure, if they've had a change in their valve function, if they've had a change in wall motion, any changes in their EF that you can see even grossly. All of that can be very, very helpful for directing next steps in management. And then what is the next steps in management? Really focusing on diuresis, especially if volume is the big issue. Trying to lower preload if that is also, if preload may be, or sorry, trying to lower afterload, excuse me, if that's a barrier to perfusion. If their blood pressure is very high, you may need to lower afterload. And that's something that cardiology can also help you with. In terms of oxygen, absolutely. If the person is desaturating, in addition to diuresing them, they still need the oxygen. And I added this diuretic chart in here just in case you want to screenshot it. I'm sure you'll also be able to find it. In general, with diuresis, we often take a home dose of diuretic if they're on a diuretic, double it, and then make it IV. If they're diuretic naive, IV Lasix-40 is a fine place to start. In general, we tend to avoid NSAIDs, thiazides, and steroids in acute decompensated heart failure because it can tend to promote volume retention. And then calcium channel blockers I've included here, particularly for the patient population of heart failure with reduced ejection fraction, because we're worried about the impact on contractility. Okay. And then I just put this here if you want to screenshot it, and also mostly as a plug for clinical problem solvers to be able to try to work through all of the etiologies. I know I'm speeding because I don't want to cramp Spenser's time. So next and last, I'm going to talk about bradyarrhythmias. So really, as always, the main questions to ask yourself: is the patient stable? Is the patient symptomatic? Is this a new rate and a new rhythm? And have we started any new medications? And I say this because you will very definitely get paged at 2 a.m. at some point. The patient has a heart rate of 45. And the question that you need to know is this, first of all, what is the patient doing at the time? Are they sleeping? Are they awake? Are they symptomatic? Are they feeling unwell? Because the essential question is this actually a normal physiologic response, or is this an arrhythmia? I've included the ACLS algorithm here to help us tease out what are the contributors to this presentation. Always worried about the H's and T's. Could this be because of hypoxia? Could this be because of hyperkalemia? Could this be because of a drug that we have given the patient, like a beta blocker? Have we been up titrating their metoprolol? Are they sleeping? And this could be because of vagal tone. And are they hypothermic? And is that why they are in this rhythm? And so always addressing for reversible causes to help us identify when we do and when we don't actually need to intervene. Now, after establishing those things, you may then be able to, after getting your EKG, after getting your IV access, making sure that they are stable, then you're going to likely call cardiology, actually, because at this point, if you've done all of this and you haven't found a reversible cause, you're probably going to want help. But absolutely, if the person is persistently bradyarrhythmic and they are now unstable, like they're hypotensive, they have altered mental status, even if they're symptomatic, that's when you would also call cardiology. I'm going to leave aside the details about atropine and dopamine and all of this stuff because by this time you already have help on board. As Tiffany mentioned, it is never wrong to call a rapid response because what that is just more hands on deck. You're saying, I need someone to put the pads on. I need somebody to be able to administer meds. I need more help for this patient who's very sick. Next, very quickly, I like to think about bradyarrhythmia in the categories of, is there something that's wrong with impulse generation? Is there something that's wrong with impulse conduction, delay, and like a delay or a block? And is there something that is now the heart is now producing an escape rhythm because there's a problem elsewhere, like higher up? So again, this is another screenshot thing. I highlighted the red because these are all of the things that you can actually do something about, or many of these things you can do something about. Many of the etiologies of sinus node dysfunction, they are not something you can do something about. They're a structural issue. They need a lot more workup. They need an intervention. Some of these extrinsic causes are things that you have the ability to do a scrupulous med review and be able to assess, are any of these things potential contributors? I'm almost done. I know I'm a little bit over time and I apologize. So I would just take a screenshot of this one and try to go through very fastidiously for reversible causes. If there's like one big takeaway from this boot camp, I think that is one of them, is just always look for what did we do that could be contributing. And then just quickly reviewing the types of heart block, because this is going to be something that you will need to know. Broadly speaking, first degree and second degree Mobitz type 1 are the ones where they tend to not be symptomatic. They tend to not cause a problem. But if they are symptomatic, that is when you need help. It's not that they are intrinsically not a problem. It's that they are less likely to cause symptoms and less likely to cause clinically relevant arrhythmia. But if they are, then they are, and then you need help and you need to call cardiology. So first degree is when you have a PR interval that is greater than 200 milliseconds. Second degree type 1 is when you have the progressively lengthening PR interval and then you drop a beat. That's the one where you kind of have a warning sign. Second degree Mobitz type 2, that's when you have the same PR interval, but then you all of a sudden drop a beat. You kind of can't predict it. And then third degree is there's no relationship between the P waves and the QRS complexes. Atria ventricular rates are completely dissociated. And so the latter two are what you are likely going to need a pacemaker for, and that's when you're calling your EP friends. And then I just include this here. This is my last slide. The only reason I include this is because let's say you get this page. This is an 80-year-old female with nausea, lightheadedness. You go and you see this, you get this EKG. You're counting out that it looks like she kind of has a rate of probably 42 or something like that. So it's slow, but you're maybe thinking, okay, I don't know, like maybe she ate something bad, maybe something weird. But if you look carefully, you'll see that there are really no P waves in this EKG. What you see is a lot of fibrillatory activity. And so now I'm much more concerned about it because this person actually is in AFib with third degree heart block. And so I call this out to say this is an indication for immediate pacing. And so just really always looking for the P waves, making sure that you know where they are, know how to track them, so that you understand, is this sinus bradycardia or is this a complete heart block? Okay, that is all. Thank you.
Am I allowed to just jump in?
Yes, let me give you access to it.
Thanks,
yes.
Ramya.
All right, you should have access now, so you should be good to go.
Perfect. All right, I am now between you and dinner. So let's get through the slides. I have been told that I talk really fast, and I'm gonna try to do that again because there's a lot to cover. So bear with me. Okay, tachyarrhythmia. So tachyarrhythmia, defined as heart rate greater than 100, your first things first is always rhythm. What is the rhythm? So get an EKG, and if it's sinus tach, I have a cheeky mnemonic for you. It's called fast pace. So fast pace, F for fever, A for acute anemia, S for all four types of shock. So that would be distributive, hypovolemic, cardiogenic, and obstructive. T for toxins, pain, P for pain or pulmonary exacerbations, A for autonomics, C for cancer, and E for endocrinopathies. And every time I see sinus tach, I am a little bit worried because I don't know what's driving the tachycardia. There's something else happening that the body is responding. So I never am hand wavy about a sinus tach, and I always run through my differential. Fast pace is my way of going through it. You don't have to use it, but always have a way of thinking about sinus tach as you see patients develop tachycardia. Now, if they're not in sinus tach, they are in tachyarrhythmia, and we think about it through via two ways. QRS greater or less than 120 kind of tells you whether this is a narrow complex tachycardia versus a wide complex tachycardia. The differential is very broad, which we don't have time to go into, but I give you here the ACLS tachyarrhythmia algorithm, and you kind of just follow that. So I'm not going to actually spend a whole lot of time on that. But I'm going to spend some time talking about atrial fibrillation because this is something we see a lot in the hospital. AFib with RVR, whether that is acute paroxysmal or persistent. And I think sometimes we end up doing a lot of harm for these patients. So a good way to think about AFib is it's a delirium of the heart. So it has to do with a poor substrate. So some sort of underlying heart disease, whether that is heart failure, plus a precipitant happening. So you're called by the nurse. Your patient is an AFib with RVR, is irregular on the tele, and the rate is, let's say, around 150. Your first branching point is, of course, unstable versus stable, as we've talked about so much through all the different talks. And if they're unstable, meaning hemodynamic instability, low blood pressure, narrow pulse pressure, or any signs of shock, and they're normotensive. So normotensive shock is totally a thing. So do not necessarily be reassured by a normal blood pressure. In those cases, you are really going to electrically cardiovert them. You're going to put on the pads and making sure it's a synchronized cardioversion, and you will take the stroke risk because you need to save this patient right now. Now, if your patient is stable, there's no signs of shock, and hemodynamically they're okay, you have time. You have time to think about this. So the next thing I think about is what is the underlying etiology? Because you may be able to reverse some of those things before reaching for your cardiac associated meds. So I use the same mnemonic with a slight difference. So still fast-paced, fever or inflammation that includes being post-op, acute anemia, all four types of shock, T for toxins again, P for pulmonary diseases, exacerbations, A for autonomic, C for cancer, and E for endocrinopathies, as well as electrolytes. And then you're going to address the underlying cause. If they're hypovolemic, give them some fluids. If they're volume overloaded, give them diuretics. Next, I think about whether I can anticoagulate them because you're really doing a favor for them if you anticoagulate them, if it's indicated. So we use the CHATS-VAS score. You can find that on MD-Calc. If it's greater than 1, you're going to anticoagulate them if they don't have a contraindication for anticoagulation. So that's like a history of a catastrophic bleed, for example. If they have amyloid, hypertrophic cardiomyopathy, or moderate to severe mitral valve stenosis, you're going to anticoagulate them either way, despite the CHATS-VAS score. So those cases with AFib, they are at high risk for a clot. You're going to anticoagulate them. And then after that, that's when I reach for these meds that we typically think about AFib with RVR. So make sure you treat the symptoms, but do no harm, because the data that shows we have to keep the heart rate below 110 is outpatient data. It's from the RACE2 trial. So really, in an inpatient acute setting, you have time to deal with this. Do not be bullied by other staff members to pushing meds if you don't need to. The four tools that we have is really A, B, C, D. So A for amiodarone. So amiodarone, we think about for all of these meds, what is their effect on chronotropes, what is the effect on inotrope, and what are your contraindications on using these meds. So A for amiodarone, it has some chronotropic effect, but it's really a rhythm control agent. So you have this chance of
chemically cardioverting the patient back into sinus. And that's why we care about whether they are anticoagulated or not. When you're asking whether you can anticoagulate, whether you can cardiovert them, you're really asking two questions. One is, what is their stroke risk now? And what is their stroke risk later? The stroke risk now can be determined if they have been in AFib for less than 48 hours and no prior history of AFib, or they're on anticoagulation for the last 3 weeks continuously. In those cases, you think their stroke risk now is low, you can go ahead and cardiovert them. If not, you can always get a CT left atrial appendage or a TEE to assess if they have a clot in their left atrial appendage. The second question you want to ask is their stroke risk later, because the highest stroke risk after cardioversion is actually 7 days after the procedure. So you want to be sure you can commit them to 4 weeks of anticoagulation after cardioversion. So you want to make sure that they don't have a contraindication to anticoagulation. A lot of times our patients are not anticoagulated and they're paroxysmal AFib, so amiodarone is not really an option for us. In those cases, beta blocker could be an option, but it is a negative chronotrope as well as a negative inotrope. So if your blood pressure is already low or you're concerned that this patient is in shock, I am worried, I am nervous to push metoprolol in that patient. Same thing with the calcium channel blocker, and even more so. It has even more chronotropic and inotropic effect, which is why it is contraindicated if the EF is less than 50%. Sometimes the ED really loves calcium channel blockers because it really works to slow down the heart rate, but you can really tip them into cardiogenic shock. So again, do no harm. So really think about this before you push the meds. And then lastly, D for digoxin. Digoxin is a great option in heart failure because it is a negative chronotrope. It blocks the AV node for the AFib with RVR, but it is a positive inotrope. So it gives the heart more kick for each squeeze. The thing you worry about for digoxin is if they have underlying CKD, you can have electrolyte derangements and digoxin toxicity. I'll leave you here with also a couple different tips about AFib with RVR, which we won't go into, but you can read them later. Next is hyperacute hypoxemia. So you're called to the bedside because your patient all of a sudden develops an oxygen requirement and there's increased work of breathing. This is adopted from a alum at Penn, Dr. Clement Lee. And you can follow him on Med Twitter. He has lots of cool ways to think about different internal medicine problems. So first you think about, again, stable, unstable. So they're ABCs. And if they're unstable, you're calling anesthesia staff for intubation. But if they're stable, you have time to think about this patient. And you have time to go ahead and listen to that patient and obtain imaging as part of your diagnostic workup. So when I listen, I always listen both, of course, the lungs, but also here at the neck for upper airway. If you hear stridor, you really think about upper airway obstruction. That includes your differential of foreign body, vocal cord dysfunction, anaphylaxis, angioedema, and excessive dynamic airway collapse, or EDAC. And if you hear lower airway concerns, that includes crackles, wheezes, or rhonchi. You're really thinking about aspiration in the acute setting, but also, of course, any alveolar filling process. So that's pus, water, and blood. And then obstruction for wheezes. When you hear nothing, you worry about pneumothorax or acute mucus plugging, which oftentimes is going to be the case for your patients on the floors, or end-stage obstruction when they're really not moving air at all. If you have normal heart, normal lung exam and normal imaging, you're really worried about a PE versus other causes. So you can, in this case, all the things are happening all at the same time. You're probably thinking about diuresing them, oxygen. You're trying to put on some oxygen. If the oxygen improves and you have a normal lung exam, the differential is really PEs high on your differential, especially if they have sinus tachycardia. If no improvement, you should at that point be getting a gas. And if there is a saturation gap, meaning the saturation on the pulse ox versus a calculated saturation on the gas based on your PaO2 is different, you're thinking about this hemoglobinemia, which of course is rare but still happens. And if there's no saturation gap, you're really thinking about intracardiac or intrapulmonary shunt, which can acutely develop in cases like pulmonary hypertension. Okay, taking a quick breather, we're now going to go through really quickly to the basic metabolic panel. That's the fishbone diagram for you. Every day when you come in to see your patients and reviewing labs,
I hope this will be helpful for you. Let's go through sodium. So hypernatremia. Hypernatremia is really a free water problem. Go ahead, you see a patient, you're admitting the sodium is 156. You go to MD Calc to calculate their free water deficit. And really, at that point, you want to start free water. We do D5 water because you care about the osmolarity of the fluids you're giving them. If you just get free water, you're going to lyse their red blood cells. So you give D5 water really for the free water. Usually you time it out, and then you whatever volume you need, you then divide it by however long you're administering that fluid. If they're hypovolemic requiring fluid resuscitation, you're going to give them isotonic fluid at the same time. So you're not going to just give D5 water. In those cases, you would do both. You need to give them something like LR for isotonic resuscitation with D5 water to correct the hypernatremia. I think about them as two different problems. So don't just do one for the patient. Make sure you do both. Next is hyponatremia. This is a fun one for us in internal medicine. There's a lot of different approaches to hyponatremia. I'm going to give you one here taught by our renal fellow. This is really a 4-question laboratory-based approach. First, you want to know if it's real, meaning if this is hypoosmolar hyponatremia. Sodium is the primary osmotically active agent in the blood. The kidney regulates that very closely. So you want to know whether it is a true hypoosmolar hyponatremia. The lab you get is serum osm. If your serum osm is greater than 295, meaning this is hyperosmolar hyponatremia, you're thinking that there's something else in the blood that's really driving that osmolarity, causing the kidney to appropriately downregulate sodium. So in that case, you're thinking hyperglycemia, ethanol, mannitol, BUN, or contrast. These are common agents that can cause hyperosmolar hyponatremia, and the treatment is really to get rid of those agents. So if it's DKA, treat the DKA. If it's ethanol, let them metabolize to freedom. If your serum osm is normal, so 275 to 295, we're really thinking this could be pseudo-hyponatremia. And that's because the lab, when it measures the sodium, it assumes the volume of your serum. And in pseudo-hyponatremia, there's either too much lipid or too much protein in the blood that causes the lab to report an error. It assumes that the volume is too high, and so when it divided by the sodium by the volume, it gives you a hyponatremia. It gives you a low sodium. That is fake. This is purely a lab error. That when I see that, I look at the protein gap to see if there's elevated paraproteins, and I see if there's a recent lipid that was sent to see if their triglyceride is very, very high. But of course, you have other things on the differential. And in this case, it could be a dual process happening at the same time. So that will be a hypo plus hypernatremia. Hypoosmolar and hyperosmolar hyponatremia happening at the same time. So now talking about kind of like the real hypoosmolar hyponatremia, where you get the serum osm, it is low indeed. It is less than 275. And next, you go to your next question, which is are your kidneys working? And for that, you look at the GFR. If it's less than 30, you're done. Kidney is the primary driver of your sodium maintenance and balance in the body. You have AKI or ESRD, treat the underlying cause, as Tiffany taught us about acute renal injury. But if your kidney is working, and then you have to keep investigating. And the next set of questions is your ADH on and is your RAS on? For ADH, you get a urine osm. If the urine osm is low, usually below 100, you're saying the ADH is actually off. So the ADH is not the culprit here. And so it probably is because the patient's either drinking too much water on their own, so primary polydipsia, or they are on the beer and toast diet, so very low solute intake. ADH has nothing to do with the hyponatremia that is happening right now. If your urine osm is elevated, it's greater than 100, you're saying that your ADH is on, and the next question you have to ask is whether your RAS is on as well. So for RAS, we get urine sodium. If it's greater than 40, it means that your ADH is on and your RAS is off. So then your differential becomes it is inappropriate ADH, so syndrome of inappropriate ADH, SIADH, or for whatever reason, ADH is on appropriately, but RAS is off and cannot be turned on. And that's when you go to adrenal insufficiency and hypothyroidism. Thiazide diuretics can also do this, so that's also on the differential. And if your RAS is on and your ADH is on, that means your urine sodium is very low. In that cases, that means for whatever reason, the kidney is not seeing enough volume. And that can be of course, hypovolemia. And so the kidney is turning on ADH and turning on RAS to reabsorb sodium and free water as much as it can. Or you can also see this in heart failure because the perfusion pressure for the kidney is very low because perfusion pressure is MAP minus the CVP, and the CVP in heart failure is very high. Cirrhosis and nephrotic syndrome are two other conditions where the intravascular effective volume is low, and so that can also do that. So differentiating those really depends on your history, and of course, management of those are very different as well. All right, next we're going to talk about potassium. Potassium, if it's high, of course, you're going to first get an EKG. You're going to look at if there are any T-wave changes, but also QRS widening and bradycardia are your late stages of your EKG changes in hyperkalemia. So don't miss those. You give calcium first to stabilize the membrane, and then insulin, dextrose, and albuterol as shifting agents. So these will shift the potassium into the intracellular compartments. But remember, you have to try to remove these potassium. So Lokelma, which decreases potassium, gut absorption, and loop diuretics and dialysis are really your agents that remove potassium. In hypokalemia, you do want to replete. You can either give PO, or if you have any reason to suspect that their gut absorption is poor, for example, in a volume overloaded state, you can give IV. The goal is potassium greater than 4, especially in cardiac and liver patients. This has the best data, but if they have risk of ventricular arrhythmia or if they have an ICD, in those cases, you want to give a potassium for a goal of greater than 4.3 based on a recent trial done by the New England Journal that was published last year. The last thing you want to be sure to do is you want to make sure that MAC is replete, because if you don't replete your MAC, your K will never be replete, as MAC blocks the wrong K channel in the collecting duct to help the body retain potassium. So if your MAG is low, you can go ahead and give PO form. Organic is better than inorganic forms. And for IV forms, you can give the 2 grams one. The 4 grams, the kidney just end up wasting the extra magnesium that you were giving them. So you can give the 2 grams in multiple doses. Goal is typically MAG greater than 2, although data is a little bit mixed about the benefits of that, although that is something we still typically do in the hospital. From a chloride standpoint, we really should be looking at the chloride with the bicarb together, because there's a channel and exchanger of chloride and bicarb in the kidney called the pendrin that you need chloride to be reabsorbed in order to get rid of bicarb. So they kind of oftentimes go in opposite direction. And in hyperchloremia and hyperchloremic acidosis, typically I think about are we causing this for the patient? For some reason, patient is getting a lot of chloride from normal saline, for example. If the chloride is low, we used to call this contraction alkalosis. It is now called a chloride depletion state, or chloride depletion alkalosis, because we know this has nothing to do with actual volume, but it has to do with the chloride concentration. In that case, if they're also volume down, you can give them normal saline to give them back the volume, or you can give them KCl if you're actually actively diuresing them for target K less than 5. For the bicarb, don't be mistaken to always say that, oh, it definitely is metabolic alkalosis or definitely metabolic acidosis. It can be a respiratory process happening at the same time. So just be sure that you get a gas if you're worried about acid-base status. I'm going to quickly talk about anion gap here. Anion gap is important because we're counting on unmeasured anions that the body is generating, and it changes your differential. So if you have a BMP, you should know the anion gap. Always correct for albumin, because albumin is another anion that is not measured by the body. If you have an anion gap, you should be calculating a delta, and I don't really use the delta ratio myself, but I just have a very simple way of doing this. So anion gap normal is 12. Bicarb normal is double that, 24. For whatever anion gap goes up, I expect my bicarb to come down. So let's say my anion gap is 20. That means my anion gap went up by 8. I expect my bicarb to go down by 8, so around 16 plus and minus 2. If it's not around that range, there's additional metabolic derangements happening, and you should be thinking about those. Lastly, about glucose, your goal inpatient is 100 to 180. We had that talk on insulin by Min, but in critically ill patients, 140 to 180. All right, very quickly, we're almost at time. So for fever of unknown origin, clinical problem solver have a great way to think about it through the I made mnemonic. I leave it to you here. But really quickly about empiric antibiotic coverage when you're admitting a patient on your own. So now thinking about CNS infection, you're really thinking about strep pneumo as your primary cause of meningitis. Cover them with ceftriaxone and zinc for that 10% of strep pneumo that is ceftriaxone resistance, add on acyclovir for HSV coverage, and for your older patients and immunocompromised patients, ampicillin for listeria coverage, making sure that their dose meningitic dosing, which is a higher dose, is very important for that CNS penetration. From a lung standpoint, your cap coverage, the most common bugs is strep pneumo, H flu, and Moraxella. And so that ceftriaxone is your great broad gram-positive and gram-negative coverage. And that's why we use that. Cover your atypicals with azithromycin or respiratory fluoroquinolones or doxy. If you're escalating, you have to know what covers MRSA and what covers Pseudomonas. So if you're escalating for MRSA coverage, you can use zinc or linezolid, not daptomycin, because surfactant is going to inactivate that. Pseudomonal coverage, you can either use cefepime or zosyn. And if there's empyema or abscesses, you want anaerobic coverage as well. Typically, for cefepime, you can add on flagyl for the anaerobic coverage, or just use zosyn. Zosyn covers both Pseudomonas and anaerobes. From a gut standpoint, you're covering a lot, including positive, negative, and anaerobes, so ceftriaxone and flagyl. For hospital-acquired escalation, you think about similarly MRSA, Pseudomonas, and Enterococcus. And those are the antibiotics that we had already talked about. For urinary tract infections, you think about E. coli as your primary agent. Ceftriaxone typically is your first choice. But if you're escalating for CODI, for example, similarly, MRSA, Enterococcus, Pseudomonas. In those cases, you can use daptomycin for MRSA coverage. For your SSTI, you think about MSSA and your your GAS, your strep, and you can use cefazolin. But when you're escalating for purulent SSTI, make sure you cover MRSA. And for your necrotizing infections that can get really, really scary, you use clindamycin or linezolid for toxin-mediated coverage for group A strep. And then you can also cover for gram-negatives and anaerobes as well, as we talked about. MDROs is kind of beyond the scope of this, but I leave that for you here. And now I leave you another graph that can be helpful for you when you're on the floors to think about what covers what. And we are done.
All right. Well, like everybody said, oops, timer's gone off. But yeah, so thank you everybody for staying this long. I hope that you all learned a lot from this presentation. We will make this available about a few weeks from now on YouTube, so be on the lookout for that. Again, sorry, I'm in the airport. Again, we will also have a survey being put out in the chat. You can scroll up and I'll send it out again shortly. But if you would like to receive a copy of these slides, please make sure to fill out that survey and leave your contact information down in the bottom question. So without any further ado, I think this session is officially closed. If some of the speakers want to stay a bit after, if anybody has any questions they would like to put on the mic, feel free to. Or if not, I think that should be it.